Welcome to this exciting presentation on post-operative nausea and vomiting. Please ensure that all mobile phones are now switched to silence. Post-operative nausea and vomiting is a common complication for surgical patients, causing anxiety and distress. Post-operative nausea and vomiting, often abbreviated PONV, refers to the nausea, retching, or emesis experienced by patients during the 24-hour period post-surgery. Delayed PONV is experienced following 24 hours post-surgery. PONV is often underestimated, holding the potential to cause severe complications such as pulmonary aspiration, electrolyte imbalance, wound infections, tissue breakdown, delayed return to diet, and delays in mobilisation. PONV also results in increased length of stay and unplanned hospital admissions, increasing hospital costs and preventable bed usage. PONV may be caused by a range of perioperative stimuli. These can include anxiety, opioid drug use, adverse drug reactions, adverse anesthetic reactions, and motion. The areas of the brain pertaining to the pathophysiology of PONV are dispersed throughout the medulla oblongata. Acetylcholine activation of the vagus nerve initiates abdominal and diaphragmatic contractions, resulting in the antiperistalsis of gastric contents. According to Stoicia, post-operative nausea and vomiting is a complication affecting between 20 and 40% of all surgery patients, with high-risk patients experiencing rates of up to 80%. A great deal of emphasis has been placed on PONV preventative measures. Hambridge depicts current risk assessment tools as being objective clinical methods of obtaining a baseline risk for PONV. Collins describes the risk assessment tools as being practical algorithms, allowing for a clinical plan of care to be established for those at risk of PONV. Rother explains the precipitating factors addressed within current risk assessments to include female gender, history of PONV or motion sickness, being a non-smoker, use of post-operative opioids, and duration of surgery. In addition to this, common surgeries associated with an increased risk of PONV include laparoscopy, laparotomy, breast surgery, and gynecological surgery. The level of risk will then decide the quantity and choice of prophylactic interventions acquired, inclusive of various antiemetics. These can include 5-HT3 receptor antagonists, NK1 receptor antagonists, corticosteroids, methylprednisones, and antihistamines. Nurses play a key role in preventing PONV by first identifying patients at risk. Nurses provide comfort measures and assess the patient throughout the post-operative course. Nurses' roles within PONV management extends to include education and reassurance to reduce anxiety and fear-related PONV, monitoring input and output, vital signs, patient positioning, and management of the administration and effects of antiemetics. Studies have presented that post-operative opioid use is a factor in increasing the PONV risk. Moreover, Stoicia stated that findings have resulted in a 6% decrease in PONV where half the post-operative opioid dose was administered, with post-operative opioid use being linked to enhanced vestibular sensitivity, negative effects on the chemoreceptor trigger zone, as well as delayed gastric emptying. The future of PONV management must address this complex issue. Smith and Seidner discuss the benefit of the opioid in post-operative pain management, which is often seen to outweigh the risk of PONV. Limited research exists in justifying that the opioid is a major cause in PONV. It has therefore been suggested that further clinical trials be undertaken. Additionally, research should be directed towards a form of opioid that is combined with agents that preserve the analgesic effect yet nullify the emetic effect. Rother has recommended that the use of other forms of analgesia be utilised, such as non-steroidal anti-inflammatory drugs. Collins suggests that non-pharmacological therapies, in conjunction with pharmacological therapies, hold the ability to lower the risk of PONV and cater for patient preference. Non-pharmacological therapies include acupressure, aromatherapy and acupuncture. However, these therapies are sparsely utilised. 16 clinical trials undertaken have provided clear evidence that P6 stimulation through acupuncture reduces the risk of nausea and vomiting. A barrier in the increased clinical use of non-pharmacological therapies is the limited research conducted into the success of these forms of therapies. The research conducted thus far holds strong ground. However, to be implemented as common practice, further research must be conducted. In addition, the cost and time associated in training healthcare workers in this form of therapy has been deemed expensive and tedious. Stocia suggests that more prospective clinical trials be undertaken, providing a stronger body of evidence in support of this conjunctional therapy. Moreover, this form of therapy has shown to reduce costs associated with an entirely pharmacological approach. Thank you for listening. I hope you have found this presentation both insightful and educational.